If you signed up in advance, you should have each had access to the grant we're going to discuss, which is a K23 application, which is a career development award for patient-oriented research. The applicant very kindly has offered her application. The pink sheet from the application, which she scored well enough on to feel very encouraged, and then her revised application, and then the final pink sheet that came along with her receiving the award. So the goal of what we're trying to do today is to really give you a sense of how study sections operate, why it's important for you to be aware of what the study section does, to be sure that you write your application in a way that really makes the job of the reviewer easier, because a reviewer who can find the information they need to represent you in front of the review panel is a happy reviewer, and the happy reviewer scores higher than an unhappy reviewer. So anyway, I think it's really valuable for you to know the things that reviewers are looking for and what things you can do to make their job easier. Probably already know this, but the scoring range is from 1 to 9, with 1 being exceptional in every way, 2 means outstanding, 3 means excellent, on down to, I've actually never seen anybody be given a 9, but what people occasionally get is they get nerfed, which means not recommended for funding, which is basically a 9, but it means that there's some fatal flaw in the application, and that influences the proceedings in a dramatic way. So, so one of the things I also should have probably told you is that the current, about 5 or 6 years ago, maybe a little more than that, NIH switched from people coming into the review room totally blind to what the other reviewers thought about a review, to requiring that everybody post their reviews online several days before the study section meets. So the people who come to the study section know what the scores are, and they've had a chance to see what the other reviewers, if they were one of the assigned reviewers, what the other reviewers liked and didn't like. And so quite often people will actually modify their score from what they posted to what they now think at the beginning of the discussion based on having read the other reviews, and that's perfectly fine. But people only change the overall impact score, which is the number we gave, and not the individual criterion scores. At the end of the whole review process, because the online submitted reviews are what NIH uses to give back to the applicants, everybody revises their reviews to be consistent with the final score they gave after all the discussion and back and forth, so that the scores are consistent with what the discussion covered. And that includes changing the criterion scores for each of the sub areas that we'll mention. And so if you have copies of the, if you don't have copies of the review, this summary statement of the review, you can get that after the meeting, but you'll see on there that each section, candidate, research plan, all those sections have an individual number, and often they're quite widely spread. Okay. I'm sorry? Not recommended for funding, an RF. Okay, yeah, so actually one of the really important features of the initial scoring process is that the study section staff can then average all the scores of the assigned reviewers and rank the grants by their initial recommended scores. And what generally happens is that about half of the applications are put into the area that's called non-scored, which means they're in the bottom half, and they don't get discussed. They get the scores that they're given are shown to the applicant when they receive their summary statement, and the summary statement has verbatim all the information that the reviewers provided in their reviews, but it's not modified by any discussion because it hasn't been discussed. So now, obviously, it's extremely helpful to have discussion and helps you to get better feedback on your application if it's not ultimately funded. But and if you're not in the top half to start with, you won't be funded. So your goal as a submitter is to get into the discussed group, so you have a chance to be funded right away, but you also will get more informed feedback that will help you revise your application and resubmit. Then the reviews are, the course of the review is that the top scoring applications get discussed first. And I think the rationale for that is so that people, the review panel at large, knows what the competition everybody's up against. I guess one other thing I should make clear is that the panel is never supposed to be saying things that relate to whether the grant should be funded or not. The panel is a peer review panel that is meant to provide an assessment of the quality of the applications, and then ultimately the NIH, each institute decides which grants it's going to fund. And they generally take the advice of the review panels and fund the top. So if they can fund 12% of the grants that are submitted, they take the top 11% and fund them based on the score, and then they may add in a few other grants based on their institutional priorities because they think it's really important that that area be studied. They may rescue a grant that was at the 15th percentile to put it into the fundable group. So anyway, the grants get discussed in descending order from their initial score. And one of the things that means is that by the end, the reviewers are pretty tired, but I think people really work hard to give honest and fair appraisals all the way along. When there is a pretty big diversity of scores, as there was for this initial submission, there's usually a little bit more discussion. And the goal of the discussion is to try to end up with people agreeing a little more on the scores. And usually, if something like this has happened, by the time the final scoring is done, the reviewers at both polls will have moved a little bit. It's not always a lot, but sometimes the discussion really changes the scores dramatically.
So just concretely with this example, so based on these preliminary impact scores, this application would have come in, I think, with a 3.3. So that's how it's averaged across the three. So that's where this applicant would fall in relation to the others that may or may not get discussed.
And also, they usually separate out like the different mechanisms, at least the panels I've been on. So a K23 would not get reviewed amidst a bunch of RO1s generally. So it would be kind of, they would talk about half of them usually within each category. Okay. So this is a 4-year K23 application by Dr. Merlin, who is an infectious disease fellowship trained physician who's also done a fellowship in palliative medicine and pain. She the candidate is really outstanding. She has done, she's currently an assistant professor at UAB, and she runs the chronic pain clinic at, in the HIV clinic. So she's had excellent training in how to manage chronic pain from a pharmacological standpoint, but as a physician, she's really coming back to get further training in behavioral methodology to kind of round out her training for chronic pain. So I think the application is really well written. It's very clear and comprehensive. The candidate's outstanding. She's had great training up until now, and she's also been very productive in her relatively short career. She's had a K-12, which is an institutional K, and she's also had a pilot grant from the UAB CTSA. So I think she's shown some really good productivity. She has 10 peer-reviewed publications, and she's first author on 8 of them. So I think the candidate is really outstanding, and I didn't note any weaknesses for the candidate. In terms of the career development plan, she talks about the various different kinds of training, and she's clearly identified her gaps in knowledge and skills. As I said, she's a physician who really doesn't have much training in chronic pain from a behavioral standpoint, and so she's really seeking to do that during her award. She's going to also get an MPH while she's during her career development and has the relevant coursework to support that, and I think that's a real strength. And one of her primary mentors is going to be will be a key teacher in her MPH course, which I think also shows commitment from the mentors. She's got, again, like a mix of formal courses, mentorship meetings with all her mentors. She's going to go to local seminars and conferences and present at conferences. So I think that will allow her to really kind of move along and become a really strong researcher. And I didn't note any weaknesses in the career development plan. Now in the research plan, what she wants to do is that she's going to do 2 studies using both qualitative and quantitative methods. What she's going to do is she's going to do an epidemiological study in which she enrolls 36 participants as part of AIM 1, and then she's going to look at factors that are related to chronic pain in this population, things like depression and other comorbidities which can impact how people experience pain. And then she was going to develop during her Career Development Award a behavioral intervention that will address those things. So I think the aims are very well developed, and I think that they will kind of lead to her goals of developing expertise in behavioral interventions. And I think it's pretty innovative because, as she notes, there really are no chronic pain behavioral interventions specifically targeting this population. And persons living with HIV have a lot of chronic pain, neuropathic pain, musculoskeletal pain that seems to be experienced and perhaps has a different pathophysiology than other chronic pain conditions among other populations. As I said, she's going to do qualitative and quantitative methods, I think, which will give her a nice blend of expertise in those areas. And she, again, is going to look at factors that are associated with chronic pain other than just experience of pain. In terms of the weakness, you know, I think this is a pretty ambitious plan that she's outlined, and she's only allowing herself 4 years, and she could have the total 5 years for doing the K23. So I would recommend that she perhaps seek that 5th year to really develop further training, because one of the things she's wanting to do is to then take this intervention, this behavioral intervention, and apply for an R34. And then if that looks promising, apply for an R01. And I would rather see her kind of develop it and pilot it all within the K, and then she'd be ready to go for an R01. So that's what I would recommend. Also, she says that, you know, they're only going to enroll 36 participants, and, you know, and she's going to look at a variety of different factors, and I'm not sure that's going to be enough participants to really look at those things. And again, because this is a non-pharmacologically focused project, I'm not really clear what the role of pharmacology is going to play, how she's going to try to control for opioid medications or NSAIDs or other things that they might be giving for chronic pain. But those were really the main weaknesses I noticed under the research plan. In terms of mentors, I think the mentors are outstanding. Her primary mentor is Dr. Sag, who's a world-renowned leader in the field of HIV. He has mentored many, many students, and I think will provide strong mentorship for her. I think she's got a co-mentoring team that is very complementary and that bring distinct expertise to this, to her training. And she obviously has some good established relationships based on the publications with her mentors. And in terms of environment, I think the environment is outstanding for this application. Do you want me to cover human subjects within this, or you want to wait?
We'll wait.
Okay. Okay. So overall, I really felt that this application was just outstanding. This is a really strong candidate with a great mentorship team, a great environment, and a really novel and important research plan that she's identified in training.
I agree with many of the comments from Reviewer 1. I think there's a lot to like about this application. I particularly think and agree with Reviewer 1 that the candidate is outstanding. She's well qualified. She's been productive. The environment is exceptional. She has access to the clinical population. And the mentors that are in place are certainly experts in their respective areas of study. I think what dampened my enthusiasm for the application and what drove my score to put it where it did was some of the concerns that I had actually about the training plan and the mentorship team. So in particular, she's proposing to develop a behavioral intervention for pain management. But in the career development plan, I really don't feel like there's much of a training focus on understanding behavioral theory. I think there's some missing components related to health psychology and mental health. She places a big emphasis on the role of depressive symptoms in relation to pain management. So I think that there's some missed opportunities there in terms of really focusing her training plan on some of those components of health psychology and mental health. And then related to that, I think the mentoring team, while they're very strong, and certainly the primary mentor is world-renowned in HIV research, I think that the candidate would benefit from more mentorship expertise related to chronic pain. There's really no chronic pain researcher on the team. And also more of that behavioral development of behavioral interventions and this mental health piece. And it may be that she needs some sort of mental health researcher given that depression and chronic pain are so comorbid, and she's really focusing on the relationship between those. In addition to those concerns I had about the mentoring team and the training plan, I had a few concerns about the approach, and in relation to specific aim 1, and that's the one where she's going to collect data to understand what variables are most relevant to target for the intervention. She mentions a lot of variables that will be collected, but I didn't really see how those were integrated into the analytic plan. So I wasn't sure what she was going to do with all of this information that she was collecting. And then another concern I had is, depression is a big focus of this application, but she's proposing to use a brief self-report measure of depression, and I think that she probably needs something more robust than that to really try to assess participants' depressive symptoms. And then finally on the research plan, to me, looking at the analytic plan proposed and then the power analysis, those didn't seem to match up to me. So similar, I think reviewer 1 brought this up, that I'm actually concerned that the sample size she's proposing may not be adequate. So again, lots of things to like about the candidate. I sort of struggled with my score here because there's so many positive things about the application, but I did feel like there were some missed opportunities related to the career development plan and the mentor team. Oh, that's my...
So all of us will maybe occasionally step out of our reviewer role just to make comments as we go along. So I want to just make the point that every time I go to a review panel, it's actually sort of a harrowing experience when you have entered all your reviews online. Once you submit your review, you can see what the other reviewers have said. And I view every time I do this as a sort of a threat of whether am I in line with what an educated person is thinking. And and so it's a great relief whenever at least one of the other reviewers gave a score close to mine. This was good this time, but I've been off a few times, and in some ways I feel like it's so that the older I get, the more I feel okay if I score people higher than the rest of the reviewers. My observation is that if I score better than the others, my observation is that first and second time reviewers tend to be tougher about the review process, and I don't know whether that's because they what the dynamic is that makes that happen, but I think I'm bringing this up just to say that I think people generally are trying to give each grant to highlight its best features, make sure that the best grants get funded, so not to sweep the dirt under the rug if there are problems, and to give reviews that are really helpful to the applicant in terms of what they can do to improve the science that they're trying to get support for. So, and another thing is that we really try to be efficient in the review process, so we don't want to go over too much stuff that's been said before, but at the same time, if something is really an issue that ought to really dominate this final impact score, then most people will bring it up a second or third time just to really give it emphasis. So in my review, I'll do a little bit of that. I was extremely positive about the applicant. This applicant is a couple of things that haven't been highlighted so far. She got an MBA while she was in medical school, which to me just speaks to the fact that she was envisioning taking some kind of leadership role in her career going forward to try to do things that are a little different from what the standard clinical physician does. She is board certified in internal medicine and infectious diseases and also in palliative care, again really underscoring her commitment to dealing with this issue of chronic pain, which she identified early in her fellowship and then in her faculty life as a really important area that has not been addressed adequately in the HIV field. So I was really impressed that she has identified this as an important area to go forward and has put herself into a potential leadership position. She, as has already been mentioned, she's the head of the chronic pain clinic subcomponent of the 1917 HIV clinic at UAB, and so she sees essentially all the patients who have issues with chronic pain, and she's very aware of the limitations that exist in not only our ability to manage the chronic pain effectively, but also is very aware of the limitations in what we understand about why chronic pain is a particular problem in patients with HIV, and so she's made a real career commitment to this. I guess one of the things I always wonder when I'm looking at a candidate who is so strong is, does she really need the K award to move forward? And I think it's already been made pretty clear that while she has fantastic clinical training, she needs mentored research training, and getting her Master's of Health degree will be very helpful for her going forward, and she just needs the mentoring and additional practice at writing grant applications and really identifying how she wants to dissect this problem of the chronic pain in HIV. So but I think she's an exceptional candidate. So the career development plan, as has been stated, I think is strong, although I think it misses a few opportunities. There are courses that she could take in how to measure pain more effectively, how to study pain specifically as a clinical variable, and I think her career plan would be stronger if that was included as part of her master's program. And additionally, to have a specific mentor who has expertise in research on pain added to her group. But otherwise, I feel like the career development plan is strong. One other thing I want to mention, so I'm going to step outside. So there are things that are discussed in the meeting that are scored, and there are other things that are unscored. So one of the things that's unscored, Dr. Cropsey already mentioned, is the protection of human subjects. If there's animals involved, there's discussion of animal use. There's discussion of responsible conduct of research training. That has to be part of every training application. And so the responsible conduct of research wouldn't be discussed yet. That's discussed after everybody gives their score. And it's discussed just because, so if there are inadequacies, NIH recognizes those, notes those, and makes sure that if the grant based on its score is going to be funded, no money is released until deficiencies in the unscored areas get resolved and fixed. But I do want to make the point that for this applicant, I'm going back as a reviewer now, so one of the things that distinguishes her is that she has a special interest in bioethics, which is an important interface related to the pain issue. She, as we'll discuss later, has taken good advantage of the normal curricula for bioethics training, but she herself teaches ethics to medical residents and fellows, and clearly has this as an interesting, a special interest of hers. I think one of the areas in which her research plan misses an opportunity is that she could include in her plan some evaluation of the bioethical aspects of pain management. How do you get information from clinical subjects who are already in a disadvantaged group about their use of opioid medications, and are they only using drugs that they're prescribed, or are they using other drugs? How do you get that information in a way that protects the subject but gives you the information that you can use to inform your clinical study? But I think most of the other issues have been really well covered by the other members of the panel, so I don't plan to go over that. Regarding the mentors, so one of the things we try to comment on is how effectively the mentors seem to have participated in development of the application. So I'm on paper, all the mentors are spectacular. I'm a little worried that one of the mentors, the co-mentor, is a head of the bioinformatics, the biostatistics, epidemiology, and research design component of the CCTS, and yet in this particular application, the actual discussion of the power calculation that went into making the study design is a little bit inadequate and makes me concerned that there hasn't been as much time spent between the applicant and this member of the mentoring team as you might have expected. And it just highlights the fact that these mentors are all exceptional, outstanding scientists, but they're also probably several of the most busy academics on campus, and have some concerns that the mentoring team might be better served by including a couple of extra people with special expertise for this particular topic and people who will be able to be a little more thoroughly engaged in the mentees' development. I'll stop.
Okay, so before we open for discussion, I just want to summarize what I'm getting from the reviews at present. So I think all the reviewers agree that this is an outstanding applicant. Career development plan, there seems to be some indication that perhaps the mentorship team needs modification to include individuals that are both or have expertise in pain management as well as perhaps a mental health provider. Additional coursework in pain management and behavioral theory has been suggested. And then with regard to the approach, the major concern I hear is with regard to sample size and power calculations. Is the sample size of 36 individuals enough really to gather meaningful data, and how actually these data will be interpreted? So based upon those points, I want to have a discussion first amongst our reviewers, and then we will open the floor to you if you have any questions or thoughts about the application itself.
So one of the things the reviewers can try to do is to try to elicit from each other more information that will help them bring their scores more into alignment with each other. Yeah.
So I know that you said that you felt she needed more training in behavioral methods, but I guess I thought with getting an MPH she would get that training. Do you see things differently?
Well, I mean, I think that will help. I guess there was two pieces to it. There is the behavior. I guess it's not clear to me, even with the MPH, how much the behavioral theory will be specifically focused on the pain management piece. So I think I would want to see more clarity on the behavioral aspects of things being specifically tied to pain management, development of those types of programs. And I think that it just needs to be, I think, clearer for me to be more confident.
And I'd like to just add, so one of the things I meant to mention earlier, which, so the applicant clearly recognizes that prevention of pain is an important part of the pain management, and so I think one of the things that would be useful is for her actual training activities to include more specific information on what kind of maneuvers there are available to try to prevent the development of pain in patients who are at risk for pain. Also, I think it'd be really valuable for her studies going forward for her to consider whether there are biomarkers for pain that might allow quantification of pain in a way that's difficult using simply psychological measurements and descriptive measures. And her training plan doesn't talk at all about the ways of using biomarkers of pain as a positive contributor to the research.
But I'm not sure a K is really going to give her the budget to be able to look at those biomarkers. I'm not really sure. I mean, it's not that big of a budget. I think she could probably save that for the RO1.
And I also, I want to make the point to the study section that I'm aware of the strengths that were brought up, and I agree the strengths are many. So I do want to express that I think the concerns I raise are addressable concerns. I think that these could be fixed, and I will likely revise my score when we revisit those in a little bit.
So what about the issue of 4 versus 5 years? What do the other reviewers think about that point that Dr. Cropsey brought up?
So I think in this case, I'm stepping outside of the review. So I'm pretty sure the NIH rules are that people can have 5 years of case support. So she is in her first year of a K-12, which means that she only has 4 years left if she were to get the grant offer or award at this point. So I think that's not an issue, but I may be wrong about this. So right. She submitted it as a 4-year, but recognizing that she will have consumed one of her years of K eligibility by the time she could get this award.
The other thing to keep in mind, so in addition to 20 reviewers that are from different academic institutions, there will be an SRO in the room, the Scientific Review Officer, which is the NIH person. So sometimes issues like this come up that there could be conflicting opinions or confusion amongst the reviewers who don't know all the rules and stipulations of NIH. So sometimes that person will step in and clarify rules or procedures. We don't have that person here at the table in role, but that just so you know, that's sort of how the process can unfold as well.
But they may make a similar comment to what Dr. Chaplin made, that she's already has a K-12 from her institution, therefore would be limited.
Right, yeah, I think it never comes up that there's a technical question about the grants that can't be answered on the spot. There's always staff available who can make sure that that gets handled effectively. One of the other things that can happen, reviewers in their enthusiasm sometimes say something like, this is such an important area, this grant really needs to get funded. And I think it's one of the best ones I've seen. And the minute the F word comes out, the scientific review officer or the study section chair interrupts and says the role of the committee is not to make decisions about or recommendations about funding. It's to provide priority scores so that the grants can be weighed against each other, and that gets handled.
So are there any questions from the other members of the section, meaning you or those people that are online? So the question is, are there individual scores given for each of the 3 sections of the application? Karen, do you want to take that? Or?
Sure. Sure. Each of the sections are scored on that 1 to 9 scale. So the candidate, the career development plan, the research plan, and then there's 2 other sections that we're scoring, the mentorship and mentorship team, and then the environmental commitment to the candidate. Each of those can have a score ranging from 1 to 9. And so it's very often the case where one section, for example, like the candidate will be scored a 1, but then the research plan could get a 7 or anywhere along that range. And you can have a variety of scores. Now then the reviewer makes an overall impact score as well, which is the score that gets submitted to the online review process, and that's the score that gets averaged across all the people who review. So all the people in the room will provide just an overall impact score. They don't score on those other criterion. And then those get averaged across there, and that's how you get your score. Okay, times 10. Okay, so whatever the average is times 10 is what your score is on a range from 10 to 90. Okay, but yes, you can have a great deal of variability on those different criterion scores.
So one of the things I just want to add that we should have addressed, and maybe I actually, one of my challenges when I'm a reviewer is that I'm usually so nervous about what I'm going to say about my own review that I don't always hear everything that the other reviewers say. So if this did get brought up, that's what happened again. But one of the things we should be commenting on explicitly in this kind of application that you all, if you provide a K-type award, need to make sure gets covered is what the level of institutional commitment is to your career development. And this is one of the things that if it's not exceptional, you're done. So you need to make sure that the letter from your department chair or division director makes it clear several things. One is that you fit into the institution's strategic plan going forward in an important way, that they want you because of what you offer. So that was made clear in the letter from the department chair, that Dr. Merlin is the expert in pain management and HIV, and particularly with her joint training in palliative care as well as in infectious diseases, she has special expertise that the institution is going to take advantage of. It's good if the person providing that letter can make clear that the institution is providing resources to support the development of that individual. There was comment that there were $20,000 a year available to the individual to do research, preliminary research work to help her get to the position of getting extramural funding, and that she has these institutional grants that were, so she has a pilot award from the CCTS, she has her K12 to help her get started. Something that's really important not to say is that so people can apply for a K award with a number of different academic levels, but most people who apply are either an instructor or an assistant professor. What's crucial not to say is that if they get this award, we'll promote them to an assistant professor. Because that's showing some degree of ambivalence about institutional commitment to the individual. The letter should say, that Dr. So-and-so will have completed 2 years as an instructor at the end of this coming year, and we plan to promote her, assuming continued progress in her academic program, to assistant professor at that time, so that it's not contingent on the funding in any way. So I would just recommend to you, if you're writing any kind of career development award like this, that you, first of all, you provide a draft of what you think the letter that your division director or department chair, or ask them if they would be happy to have a draft. Most people will say yes, because it helps them to not spend so long on writing the letter. You can put in personal things about your specific situation that you think ought to be included in there. And but then at the end, make sure that the letter, so there are letters that get submitted as a part of the body of the grant, so it's clear that you've read them. It's not that there's anything secret about it. There are also letters of recommendation that are not shown to the applicant that get sent in separately. But in this case, there are letters that are institutional commitment letters. You get to see those. Make sure that you show them to somebody who's experienced at what that kind of letter ought to say, because not all division directors are very experienced at doing this, and you need to get a 1 on institutional commitment. You need to get a 1 on you as the candidate. You need to get certain areas that if you don't get a 1, it's because you haven't done your homework ahead of time and you're just really biasing your chances against yourself. So there are a number of people in the CCTS. There's particularly several people who are really good at helping you make sure the career development plan covers all the critical areas. Make sure you get someone to read who's experienced at that and can help you get things fixed if they're aware of problems.
Okay, thank you, David. So now we will get the revised impact score. Karen, your initial score was 1?
Yeah, I'm going to drop to
A 2?
Yes.
Okay. Gareth, your initial score was 5.
I'm going to move to a 4.
You're at a 4. And David, your initial score was 4.
You know, I already knew the candidate was outstanding, and I think the concerns I have about the plan, I'm going to keep my score as 4.
Okay, so we have 2, 4, and 4. So based upon these scores, the other members of the study section would actually choose a score that they prefer to vote on.
Outside the range. Score outside the range.
Yeah. So people are if people in the general panel are at liberty to score whatever they want, but if they're going to score outside the range that's recommended, so here the range is 2 to 4. If anybody in the audience wants to score outside of 2, 3, or 4, they should raise their hand and give an explanation of why they want to do that, so that the rest of the members of the panel know that that's happening and hear what it was that made them want to be outside this range. And occasionally that provokes a lot more discussion, and not too often. And generally the NIH asks the people who are going to vote outside the range write a short paragraph about why they're doing it that gets submitted as part of the report of the grant. If everybody agrees on 3 as the number, for example, of the 3 reviewers, then the range is defined as 2 to 4, because they want everybody to have some room to be able to give a little bit something different from the assigned reviewers.
So
that's study section specific.
Oh, maybe
Yeah.
that is study section.
So I've never been in a study section. The range is the range, whether it's 3 to 3 or 1 to 9, and that's what people can vote within, and then they can vote outside the range. So I've never had them where if it's 3 to 3, they say, well, you can vote between 2 to 4. I think that must be, maybe that's more of a basic science study section issue, but I'm on clinical science study sections, and that's never been the case for any of the ones I've been on. Is that?
Yeah, if you want to vote out of 3, you still raise your hand.
Right.
That's
And you can vote better or you can vote worse. Usually when people vote outside the range, it's worse. Just that's been my experience. So occasionally people vote better, but usually it's worse. And I'll just make a comment too. Sometimes the more discussion is not better. Sometimes it's, I have one of my chairs refer to it as death by 1,000 scratches. And so sometimes as it goes on and people are picking it apart, that can really, the longer it goes on, sometimes the worse it can get.
Okay, so what we'll do now is we will discuss responsible conduct of research and human subjects.
So usually the reviewer one is the only one who makes comments unless there's something egregiously left out that needs to be discussed.
So I didn't have any problems with protection of human subjects. It's an epidemiological study. And in terms of her training and responsible conduct of research, I thought it was all fine. She's going to take formal courses in scientific integrity and seminars on responsible conduct of research that are offered through the CTSA as well as through the city as part of IRB training. I think she also mentions that she's going to have weekly regular meetings where she'll discuss ethical concerns and issues with Dr. Sag, who clearly has been an expert in this area. I thought everything looked good from a human subject standpoint.
Okay, thank you, Karen. Before we move on, I guess, to the resubmission of this application, are there any questions? Oh, sorry, David.
So there are a few other things that have to get sort of authorized as okay. So there's the current NIH rules require that there be inclusion of males and females and all ages unless there's a specific reason to exclude certain ages from the study. So the study gets discussed in terms of its gender inclusion and minorities and children. And then if there's any biohazard concerns, that also has to be described. And then finally, so for K awards, there's never any concerns about the budget, but because there isn't enough money to do what needs to be done usually anyway. But there is always some mention of whether there were any budget concerns, and often sometimes the study section will say that there was too much money requested for certain kinds of things, or that there wasn't enough money to possibly do the study, and so that's a real concern.
Yeah, I just want to make a comment. NIH has recently changed, and now you're evaluating in three other criteria. There's rigor, reproducibility, and then biological variables, which for clinical research is things like sex inclusion, so enough adequate female and male, and can you do kind of comparison analyses between men and women, for example. Rigor and reproducibility refers to, is the methodology, well enough explained and understand that someone else could reproduce it, because that's been an issue. And then the other one is rigor, reproduce. I guess they're biological, yeah. So those three. Now this one, because it was several years ago, doesn't include that. The other thing that NIH recently changed is that it used to be that children were considered anyone between the ages of 18, or really below 21. So, and even adult studies that recruited people 18 and older, you had to talk about children in terms of protection of children and recruitment of children, even if they were 18. Now NIH has changed that so that it's children are defined more conventionally as anyone less than 18 years of age. Oh yes, scientific premise, thank you. Right. So those get all evaluated for Ks through R01s. In terms of the budget, usually they're limited for Ks by institute. Some institutes have $50,000 for your research budget, and others have $25,000. And then the salary is limited as well, so that they only pay for investigator salary. Mentor salaries don't get paid at all. It's volunteer. And so the investigator salary for K is limited to $90,000, I believe, across institutes. Now that changes for R01s, and it's a whole different ballgame for those. So.
Some institutes have a program where in the final 2 years of your K award you can apply for a supplemental research budget, which is often, I think, an additional $50,000, and it's almost automatic if you write the paperwork appropriately, and it's meant to give you the chance to be preparing to transition your study to a broader study that would be supported through some R mechanism afterwards.
So it is true that these things, that after everyone has entered their scores and that's finished, then there's the discussion of the budget and the protection of human subjects. So those shouldn't be scored. But two things I want to say is, if there is an issue with your human subjects, then NIH is not going to be able to, even if it gets well scored, you're going to have to work with NIH to get that resolved before they'll fund it. So you don't want to be in that position to have human subject concerns. And then as far as the budget goes, it's not scored. However, I think reviewers will look at your budget, particularly your budget justification, and if it looks very naive, or you've grossly left out things or clearly mispriced things, it does sort of speak to, how ready you are for this. Maybe not so much for a K-word, because you're right, the budget is what the budget is, but for our series particularly, they're going to look at that, and if they feel like it doesn't seem reasonable or it seems a bit naive, it shouldn't impact your score, but I think it can.
Now, on the review panels I've been on in the last year, human subjects is a scoreable criteria. We actually discuss it before we do scores. So you want to make sure that you really cover don't leave your human subjects section as an afterthought. Really make sure that you're addressing important issues on how to protect your human subjects. Because if they see something very egregious, like, I don't know, you're recruiting kids and you're not getting parental consent, for example, that's going to really impact your score, or it could potentially impact your score. In terms of budgets, just, again, it's not really an issue with the K, but like an R01, when I see a budget that's $499,999 every year, I'm going to look at that budget very closely, because the cap, without getting special NIH permission, is $500,000 a year. So when I see a budget that's just seems to be right there, I kind of wonder if that's really the case across all 4 years.
Okay, so why don't we take a 5-minute break, and then we'll go through the review of the renewal, and if you don't need to spend more than a couple of minutes, that'd be great, because I know Dr. Dutton at least needs to leave at 10, so maybe. But usually, if there are reviewers who reviewed it the first time, at least one, often two of them will be the same when it gets reviewed the second time. They're not always the same primary reviewer and secondary reviewer. So in that spirit, we're moving on to have different primary and secondary reviewers. I, as the least qualified, am staying as reviewer 3.
Okay, thank you, David. So we will be reviewing the application development of a behavioral intervention for chronic pain in HIV-positive individuals from Dr. Jessica Merlin at UAB. Dr. Gareth Dutton will be the primary reviewer, Dr. Karen Cropsey, secondary reviewer, and Dr. David Chaplin will be the third reviewer. Could I have your initial impact scores, please, starting with Dr. Dutton? Dr. Dutton is a 1.
I gave it a 1.
Dr. Cropsey is a 1.
David, a 2.
And Dr. Chaplin is a 2.
So this is a resubmission from a highly qualified candidate, and she was very responsive, extremely responsive to the feedback from the first reviews. And I think the application is even stronger than before because of that. She continues to be well qualified. She has extensive training in this area of research. She has a background in internal medicine, infectious disease, and palliative care. Let me time out here for a second. So normally this would be happening months later, right? So just as Karen sort of gave a more detailed background as reviewer 1, that would normally be my job, but since instead of this being months ago, it was moments ago. A lot of things have not changed, so I'm going to do a more abbreviated version as reviewer 1 than what you would typically see in a real study section.
Can I make one comment too? One of the things on re-review is the reviewers are not allowed to mention the previous score. You can say, and you can't even mention that it was previously scored. Now, of course, you will have the first reviews. As a reviewer, you will see those reviews in your assignment, and so you'll know that it got a score of a 39 the first time and that it was pretty close or whatever. For R01s, you'll see you'll see all that as well. But you're not allowed to say, it got a 39 the first time. I don't want to score it worse, so I gave it a 1. You're not allowed to mention any of that. The only thing you can really mention is, like Dr. Dutton said, is that they were responsive to the previous critiques. Is that consistent?
Mm-hmm. Yep. I think that just to recap, the research and training plan are very well integrated with each other. It's focusing on the development of a behavioral intervention for chronic pain management among people living with HIV. This is, as indicated in the previous reviews, is a significant topic. This candidate is really, I think, ideally suited to address this issue given her background and previous training, but she continues to make a really compelling case for why additional training is needed to really supplement and launch her into an independent career as a researcher in this area. The resubmission continues to include 2 aims, but she's shuffled things around a bit, again, in response to the previous reviews. So in this current resubmission, the specific aim 1 has to do with the intervention mapping to develop the components of the intervention with some pilot testing and qualitative data collection with a small group of participants. And now specific aim 2 is actually a small pilot RCT. So she's proposing to compare the intervention to a control arm. And that, I think, is responsive to the previous concern. So the previous aim that had to do with more epidemiological data collection to look at associations, that's gone away. But actually I see that as a strength to this resubmission because she in the meantime has collected some additional preliminary data that I think has sort of addressed that issue outside of the K, and so I think this is going to speed things up for her and help her move more quickly into the trial and then the future R01. In addition to being responsive in terms of the redesign of the aims, there's other positive changes that she's made in relation to the mentoring team and the training plan. So she's added, in addition to continuing to have Dr. Sag as the primary mentor who is on site at UAB and a recognized expert in HIV research, she's added 2 co-mentors that are not at UAB but are definitely content experts. So she has an investigator at Yale who has expertise in behavioral interventions for chronic pain. And she also has a mentor at UCSF now who has specialization in health psychology and mental health research. And I think those two are really key additions to her mentoring team that will really complement the on-site mentorship she'll continue to receive from Dr. Sag. Other changes that she made to the research plan, there were some previous concerns about her using a self-report measure of depressive symptoms, and she has now indicated replacing that with a structured clinical interview to assess depressive symptoms and diagnoses of both depression and other mental health issues, and that's really the gold standard here, and so I was happy to see that improvement in the methodology. And I also think that the application is stronger in terms of grounding the intervention in behavior theory, so I think there's more attention been paid from her and probably the mentoring team that really comes through to show that there's more depth in terms of describing how the intervention is grounded in behavioral theory. I think the weaknesses here I think are very few and very, very minor, particularly relative to the strengths. I think the only concerns I have really relate to the research plan. But I think it's a situation where she's proposing to do more than is really necessary. So for instance, with the first aim, she's proposing to collect data both from focus groups and cognitive interviews, individual interviews, and I don't really see the necessity of doing both. I'm not really sure that she needs both of those. And she's also proposing to collect some quantitative data along with the qualitative data in aim 1. And again, I'm not really sure what she's planning to do with that. I'm not sure that it's necessary. I think the analytic plan is still not as strong and robust as it could be. It's sort of lacking in some details. And then the only other concern I have, and this is very minor, is that the two mentors are very geographically distant from UAB. One's in Connecticut and one's in California. But I think she's done a nice job of addressing that issue. They have some ties to UAB. One investigator in particular has some collaborations happening at UAB. So I think she's done a nice job of addressing how that mentorship is going to happen. So I'm really not that concerned about them not being local. So I mean, to summarize, great candidate, very responsive application. I think the training plan, the mentoring team ideally fit into the gaps in her training to help her launch into the R01. I'm very enthusiastic about this application.
I really agree with everything Dr. Dutton had to say. I mean, I think this is just an outstanding candidate, and I really feel that she was very responsive to the previous critiques and made the necessary changes that he spoke of. You know, I don't want to, again, I thought the research plan was much better, and I thought that, the significance and impact of this is really important. One of the things I was a little concerned about was, she really states that this would be the first behavioral intervention for HIV, so I was a little skeptical of that. So I went and looked, and indeed, there doesn't seem to be much out there for pain, and so that really reassured me of the significance of this project. There were a couple weaknesses that were really very minor within the research plan. Specifically, I still wasn't convinced about the theoretical framework that she has chosen. She talks about many different frameworks. I was a little confused about which one she was really going to go with. But I think that ultimately it's important that she recognizes that there's a broad array of behavioral frameworks, and I'm sure with her mentors she will choose the appropriate one. I also, as Dr. Dutton mentioned, the research analytic plan was a little sparse, but I think that's because she's really focusing on the acceptability and feasibility, as is appropriate in a small pilot trial. However, she doesn't really operationalize how she's going to assess this acceptability and feasibility. So that was another kind of lingering concern, but really I don't want to focus too much on those because I really found them to be very minor, that I think her mentors will really help her work through those issues, and overall I was just really impressed and enthusiastic about this application.
So I basically agree that, so one thing I'd just like to highlight is that the applicant has published 2 additional manuscripts since the initial submission, so she obviously is still being very productive, and I agree that the new research team is a strength. One thing that's worth highlighting is that regarding the relationship with one of the off-site mentors, the applicant has also brought in as an advisor Dr. Gooden at UAB, who was a trainee with one of the new co-mentors from California. So that's one additional person who can help to be sure to integrate the relationship with the new mentors. And I agree that there's still a few little issues about how social behavioral theory and cognitive behavioral therapy approaches are going to be brought together, but she has this fantastic team, and it's an outstanding revised application. So I wanted to take a second to just comment on the challenge of dealing with the mentorship team. So I think one of the things people have to balance is being sure that the mentorship team has the expertise you need without becoming so big that it's cumbersome. And I think in thinking about that, this inclusion of Dr. Gooden as an advisor rather than as a local co-mentor maybe was partly considered in that kind of a way, that a mentoring team of 5 is getting to be pretty big, and that's what she has at this point. But you know, if your team begins to be big, you need to define everyone's roles very clearly. You need to make sure that each of the mentors in the statements they write acknowledge what their own roles are, so that there's not going to appear to be conflict among the mentoring team. Some people actually include a little bit of a discussion of what they'll do if they get conflicting advice and how they'll resolve that kind of situation. That's a good thing to do, although you usually don't have to do it if you have 3 mentors. And most people think it's a good idea to have a scientific mentor, a career mentor, and more often now people are beginning to include having some kind of peer mentor or some sort of institutional other support for making sure career development goes smoothly. One of the things the CCTS is beginning to encourage people to do is to have an administrative kind of support person who may not be called a mentor per se, but functions as part of the mentoring team, to make sure that you know how to work your way around all the stuff of managing your academic life in a complex institution. So somebody who knows how to make sure things get pushed through the grants and contracts office effectively, how to handle the IRB effectively, how to do all those things. So anyway, I think here she used as an advisor a person who could help with validating the mentoring team in a way that was pretty smart. When you have people who are off-site like this, it's really important to make very clear plans of how you're going to have strong communication. And one way to do that is to include at least 1 or 2 face-to-face meetings during the course of each year. There's not, I mean, the non-salary money that's available in the budget can be used for that kind of travel. That's okay. So that's, you can either bring, I mean, the ideal thing is to bring the off-site mentor to where you are so that they can interact with the other mentors face-to-face as well. But you want to have some sort of Skype meetings where it's not just you one-on-one with this off-site mentor, but the part of the mentoring team can all be together, so you keep a cohesive mentoring philosophy. I don't know if others want to add to that discussion.
Yeah, one other thing is all of her mentors are pretty senior, which is what most people are going to look for, and that may be why she had Dr. Gooden, who is a relatively new faculty at this time that he came in and was assistant professor as more of a consultant rather than a mentor, just so that you think about those issues. Usually associate professor or higher considered.
Right. Okay.
Okay, so to briefly summarize, outstanding revised application is what I'm here. The strengths are far outweigh any weaknesses, and both the primary and the secondary reviewer show great enthusiasm for this application. So I think really the discussion should be very brief. Are there any comments from or discussion from the review panel? No?
I'll just step out of the reviewer role for a second. So Dr. Merlin really addressed in a pretty well point-by-point away most of the comments that she got that were concerns in the pink sheet. Now, there's no mention of bringing biological biomarkers of pain into it in this revised version. So clearly you don't have to answer everything, and probably people accepted that was that either they didn't notice that was a suggestion that she didn't decide to take, or that it was something that was not so reasonable to include within a grant of this scope. So you don't have to address every single thing, but you really need to be careful to identify every significant concern, and either sometimes the reviewer has misinterpreted what you initially intended to do, and don't just assume that the reviewer is an idiot. You take this as an example or an opportunity to learn to communicate more effectively with your own ideas and realize that you probably didn't express this as clearly as you should have. So you can fix that just as you would in a manuscript you wrote, that you'll restate it in a way that'll make it easier for people to understand, even if you're not going to actually change what you are planning to do.
And again, she kept it at a 4-year K23, so she didn't make that change. Perhaps she wasn't to be stated.
Okay, so we will hear the revised scores. Gareth, your initial score was a 1.
I'll stay at a 1.
Stay at a 1. Karen?
I'm going to stay at a 1.
Okay. David?
I think there are still a few questions about the research plan, and the way in which she was going to communicate with her offsite mentors was not well enough described for me to give a 1. I'll stay with a 2.
All right, so David stays with a 2. So our scores are 1, 1, and 2, so our range is between 1 and 2. So you can go ahead and vote.
Yeah, you can still ask if anyone's going to outside.
Right. Okay.
Okay, so she ended up with a 1.3 average, or 13 score out of this. So most people were convinced that the score of 1 was appropriate, but there were a few people who thought there were other applications that were stronger. So I think since there aren't any issues about the other non-scored parts of the application, we would go through and have discussed there weren't any human subjects concerns, but we would discuss all the other issues of bioethics, responsible kinds of research, the gender minorities, and age equity in the study, and all those other things, and the budget, which there were no concerns with that. So I guess we'll call it quits for the formal review. We're happy to answer any questions you have about the general strategy or what this may have brought up. I think one of the things I just like to highlight is you've seen so look at what the pink sheet looks like. It's really important to see what the pink sheet says. You can actually get a copy of the form that the reviewers have to fill out by going to the NIH website and looking under forms for, I'm not sure exactly where it is. I'll have to give you that information if you can't find it easily yourself. But the form actually includes a lot of suggested areas that you should respond about. And so you should be aware of those, because if you can answer the questions that the reviewer is going to have to answer in your application in a way that the reviewer can easily find, then I've definitely have had times where I've cut and pasted out of the grant words that answered the question that I was supposed to be responding to, and that's a great help to the reviewer. So don't be afraid to answer the question. One of the things in our grant you have to talk about explicitly is significance of the project. So your project needs to be perceived as significant, and you want to be explicit about how it is significant. So in this application, you needed to address very specific issues in career development. Use the words that make it clear what aspect of those criteria you're responding to, and don't be afraid to be pretty explicit.
Also, you'll notice in her reviews that there's a meeting roster here which will list all the people who are on the review committee. Now this meeting roster is available online a month before your review. So you can go on to NIH and see what study section it was assigned to. See you later. And then you can go online and look to see who's going to be on the panel a month ahead of time. NIH is required to post this. You are never, ever, ever supposed to reach out to these people, ever, before or after the review. And it certainly won't tell you which were the 3 primary reviewers for your grant. It's all just mixed in. But it's information for you to know, so that if you know, like a colleague on here who has a certain, I don't know, theoretical model that they like, for example, it gives you good information for maybe how you might want to frame it. Or if you don't agree, you might want to explain in your grant why you made the choices that you did. But you never are allowed to talk to these people about your grant.
Okay. Are there any questions or concerns, issues you want to talk about a little more? Yes. Right, so the question is whether if your grant includes human subjects as part of the application, is it helpful to have an already approved IRB and to have shown that you can access the patient population that you're going to be studying. So, so it's not a non-starter to not have your IRB in place yet, but it's crucial to be able to document that what you're trying to do is feasible. And part of the feasibility is having evidence that, first of all, that the pool of patients or subjects that you're going to draw from is adequate, recognizing that you can't enroll everybody who has whatever criteria it is, a disease you're trying to study. You're not going to be successful at that. So you need to have a large enough pool. Sometimes you need to have multi-centers available to draw from, but you need to show that you're able to actually recruit people in order to be feasible. I guess in this setting where she is proposing an intervention a little bit down the road and setting it up as a randomized trial, she needs to show that she was able to access subjects for study, but not that she could enroll them in this kind of a trial specifically. So, but it's, yeah.
Usually in human subjects research, you will talk about your recruitment methods. So for example, what she probably included in her grant was just the number of people on opioid medications, which that information would be available to them because it's all in the EHR as part of the 1917 clinic. She could talk about, the types of opioid medications that they're on, and things like that can show that she can recruit those populations, like the percentage of people within clinic who have chronic pain. They have measures like that, I know, through 1917 clinic. So she probably had that information she pulled together as part of a preliminary study to demonstrate the feasibility of this. And I think you would want to do something similar. Getting IRB approval ahead of time is, of course, a bonus. You're certainly going to need it before they'll release the funds, because that'll be part of your just-in-time stuff that you submit. But it's not necessary at the time that you submit it. In fact, our IRB is probably not going to see a bunch of applications for studies that may or may not occur based on the funding, whether or not it gets funded through NIH. Does that make sense? So you might want to have done a pilot trial, for example.
Section of the preliminary data the science can come from your previous work. How important it is to build preliminary data on the aim that you like, when you have aim to do a physical research, and to have X biomarker and report that as data versus it comes from science, because you have things. They make that.
I mean, I think you're going to want preliminary data that is going to support the aims of your project. You don't need to prove your aims already. That's the point of the grant, right? But you need to have some pretty strong data that suggests that what you think is going to happen is likely to happen, or that you have a good likelihood of discovering what the truth might be. Okay. But yeah, again, review committees will weigh it a little bit differently. Some people might see, you know, a small pilot with 4 people compelling. Some people, depending on what it is, some people would say, oh, that's not really adequate, or I can't really interpret 4 people, for example. It just depends on what you're looking at. But all grants require preliminary data, even Ks, except for R21s, which don't require preliminary data. But those are somewhat unique mechanisms.
And depending on the study section, even for R21s, a grant that has preliminary data is likely to score better than one that doesn't have preliminary data. So feasibility is hard to document without some preliminary data. So in this particular case, the score went from an original score of 39 to the final score was 13, and that's a very large jump forward. Now, I think this should give everybody hope that you can achieve that. Now, she had several things really going in her favor. First of all, she was recognized as an outstanding candidate. She didn't need to fix herself in any major way. So if you start out with candidate scoring 1 in this kind of setting, your opportunity to improve your score a lot is great. If your initial score as a candidate is 3, which you'll see on this, so that doesn't that shows up on the pink sheet what each of the criterion, so candidate, mentor, training plan, each of those has a separate score. If your score is 3, you really need to figure out why it was, and you've got to change that. And it's usually not something that you can fix by rewriting. It usually is that you don't have enough, you haven't published enough yet, or your documented commitment to research isn't strong enough yet. And if that's the case, you need to have a heart-to-heart with your institution and make sure that they are prepared to support you while you fix that. And that's going to take, you won't be able to turn that around and resubmit in the next deadline for the grant. You'll have to develop your research portfolio a little more. If the problem is that the mentor wasn't strong, then often you can fix that by, you may need that mentor as a scientific provider of information and advice, but you may need to bring in some additional very well-established mentors to give the reviewers confidence that the mentoring team will be able to guide you effectively. And so most things can be fixed. Some of them take a little longer than others. In this case, the things that needed to be fixed could all be done by some restructuring without having to get a lot of new data, without having to, I mean, the fact that she did publish additional papers was great, but she would have gotten a 1 for candidate, again, without having published anything in that short intervening time. So that wasn't an essential part of the new scoring. So I would just encourage you, first of all, recognize that almost nobody gets their grants funded on the first application, so be emotionally prepared for that. It's still punishing every time you don't get the score you hope you would get. It's not easy to take, but and don't respond, don't start feverishly addressing things instantly. Take a little time to think about it, bring together your mentoring team, and talk through what issues you really need to address and what ones you may be able to ignore, and bring in as much help as you can get. I think you probably all are aware that many of the research centers here have components that are designed to help people write their grants. I know the CFAR does, the CCTS and the Cancer Center both have systems to help you to have a pre-review of your grant before it's submitted so that you can have additional input. The CCTS has something called the Nascent Project Panel, which is really designed to be before you've finished, before you've really written most of your grant. So if you either are planning to write a grant and you want to really talk through whether the aims make sense, whether it's your career development plan is appropriate, you can ask for the nascent panel to meet and you can present your plans and they will give you feedback. If you have a major rewrite to do that really involves restructuring what you're doing and you want to talk about it before you go to the trouble of writing it again, the nascent panel can be very helpful for that. Or you can use the other CCTS program is called the PDQs, or Panels Done Quickly, which is a more focused on the scientific details of the project, but that group can be brought together usually within 2 weeks of when you ask for it, and the group will read what you've got to read and give you feedback and discuss with you any major questions you have. Take advantage of that because you know, it's much better to spend the time before you submit rather than having to wait. I mean, one of the hardest things about the NIH process is that you submit your grant, then you wait 4 months or more before you get the review back. By then you have to really refocus on what you wrote. You have to figure out for yourself. You have to review your own grant by yourself again to figure out exactly what you said. So if you can get input along the way as you're working, it's extremely helpful. And do take advantage of that.
The other thing is on your reviews, you'll see there's a program contact. This is your program officer, and these people are scientists. They work for NIH, but they are scientists, just like the SRO who organizes the committee meeting is a scientist who reads all the applications to understand the content to make sure they get the appropriate scientific expertise in the review. The SRO is the one who asks for reviewers and things like that. Your program contact is the person to talk to about the science after it's been reviewed. They won't want to hear from you until you get your reviews back or your pink sheets. But they may have attended the meeting, so they may have heard the discussion. Sometimes they haven't, but they can go through your reviews with you and can kind of think in their own head what are the things that are the most important and critical to address, and so they can be very helpful. Sometimes even they will read like a specific aims page or things like that ahead of time for you. And it's always a good idea to talk to these people before you submit your initial submission, your program officers of the different institutes, so that you can find out, is this something that, you know, maybe is already being considered for funding, for example? They've already got a grant that's kind of similar to the same idea that you have. Or is this within program priorities? Is there a way you could tweak it to make it more within their priorities and things like that? So they can provide a lot of helpful guidance. Another resource for you to know about is the NIH Reporter. This is an online database that contains all the funded applications that have been funded by NIH in the last, I don't know, 20, 30 years. So you can go online to see if someone's actually done the study that you've done, because it might not be published. Maybe they didn't find very good results, for example. And it's always helpful to go and look at those things to make sure that you're not proposing something that got funded 10 years ago but somehow didn't get published because maybe it didn't pan out or something. Any questions on that?
Okay, last chance. Okay, well, thank you very much for participating and joining us here. We'll be sending out a quick survey asking you to give us feedback on the process. Please do take a minute to give us your thoughts about ways we can make this more useful. If there are particular topics you want to have included, we'll likely have another mock study section next year, so if there are things you can suggest that'll make this more valuable for the people who follow you,